Hello everyone, I'm Dr. Chinu Agrawal here at the beautiful city of Prague, Czech Republic at the International Congress of Psychology and meeting with Dr. Arthur Evans, the CEO of APA, currently a name in community mental health, policy, and change management in the organizations. Friends, Dr. Arthur Evans is going to visit India very soon, and we are going to discuss a lot of things with him when he is in India regarding policy, regarding community mental health, regarding social emotional learning, regarding lots of aspects of psychology which we need at our country. Here, I'm just getting the opportunity to get a glimpse of his thoughts on various issues. Hi, Dr. Arthur.
Hello, how are you?
I'm good.
Thank you so much for inviting me.
Thank you. Dr. Arthur, the subject that is nearest to your heart is community mental health.
Yes, it is.
So let's open the discussion with that topic as to what is it that you have done so far and what is it that you want to do ahead in this field?
Yeah. So I think of my career in three phases. The first phase was I came into the field, as a new young psychologist, and I just wanted to do a good job. The way things were set up was the way I ran them. But what I started to learn over time was that there was a lot of room for improvement in community mental health. And around the early 90s, late 90s, a movement in the United States started to occur around recovery-oriented care. And so the next phase in my career was really looking at what does that mean? What does it mean to be recovery-oriented? And I would describe it like this. When I came into the field, the goal was to treat people and to help their symptoms go away.
Yeah.
And then we assumed that if we could help their symptoms go away, that people could have the kind of life that they wanted.
Yeah.
Recovery movement really challenged that idea in a couple of important ways. One of the ways is that it acknowledged that sometimes people will not be symptom free.
Yeah.
For example, people who have schizophrenia, they may continue to have symptoms for a very long time or throughout their life. That doesn't mean they can't have a fulfilling life.
Yeah.
So one idea was that we should be really looking at and focusing on what are the outcomes that people want, doing that in a way where we're partnering with the person. So another key concept was moving away from this hierarchical relationship and saying, I'm the clinician, I'm the expert, you have to listen to me, I know everything, to I know some things, you know much more about your life than I do. We're going to partner together to help you find a path to recovery. So that second phase was really about how do you reorient programs, how do you reorient clinicians, and more importantly for me, because I was in public policy, how do you reorient entire systems to have that kind of focus on the kinds of outcomes that people want as opposed to the outcomes that we say people should have.
Yeah.
The third phase came about when we started to recognize, actually when we were doing the recovery work, one of the ideas that we had early on was that if we want people to recover, to have a fulfilling life, that we had to do some work in the community to change community attitudes.
Yes.
And so we started going into communities, getting out of the treatment, what I call the treatment black box, and going into communities and saying to communities, we want these places, your churches, your community centers and so forth, to be welcoming to people who have mental illness. But what we found was there were a lot of people in the community that still had issues. They weren't in treatment, but they clearly had issues. Some of them had issues that were required professional intervention, but many of them had what we would call subclinical issues. They were struggling. They may have experiencing anxiety. They may have been experiencing stress. They may not have had a diagnosis, but they clearly could have benefited from some of the interventions that we
Yeah.
could do as mental health
Yeah.
professionals. And that really moved us to really thinking more about a population health approach, which simply means we're not only interested in helping people have a diagnosis, but we're really interested in helping the entire community to be psychologically well and to have psychological well-being.
Yeah.
So those sort of the three phases, and I think my whole career has been about how do you change organizations and systems to realize those kinds of outcomes and that utilize that kind of framework.
Yeah. Very interesting. And Arthur, when I was an intern and I was working at a psychiatric hospital, the patients with a psychosis diagnosis, whether it was schizophrenia or acute psychosis or other things, what we actually were doing was just prescribing them medicines, and following up on the medicines every fortnightly, and not caring about what kind of life they are having. And they were living just like a liability for the families, and the families didn't after a point of time they didn't want to have them,
Yep.
and they were treated like a burden.
Yep.
And the attitudes towards fulfilling life, and that they have some hope in the community and they can be an integral part of the community, was a far thought idea. And and
but that's exactly why that work of the initial work of moving to recovery orientation was so exciting and so fun, frankly, because what we were doing was really challenging that way of thinking that people with these illnesses are here for us to take care of them, as opposed to thinking about it, we're here to help you recover from and have the most fulfilling life that you can have. That is a very different way of thinking.
Looking at it.
And what, and I think, as psychologists, what we know from the research is that most people with serious mental illnesses will recover. They'll recover. Courtney Harding's work, for example, showed that when she looked at people who had been discharged from state hospitals, those are places where we had basically warehoused people for many years. And when we started to deinstitutionalize, move those people to the community, she went and looked at how were they doing? Because if you were to believe what what people were saying at the time, you would have thought they would have been a complete failure, that they would have been homeless. But that's not what she found. She found about a third of them were asymptomatic. They weren't experiencing any symptoms, living well in the community. About a third were living in the community. They were having some residual symptoms. Then about a third were living, really kind of struggling.
Yeah.
So, and I believe that, given the time that she did that, we have developed new therapeutic techniques since then. We've developed different kinds of supports that today, I think that number, that third, would be a lot less than a third. Yeah. But the overwhelming majority of people can do well. They can do well. It's just we have to believe that and then reorient our services and our approach so that people actually can do well.
Yeah, but in India, the medical model still believes that a diagnosis like schizophrenia is a lifetime diagnosis.
Yes, I know. That's the way we're all trained. Yes, we're all trained that way. But it doesn't follow the data. And I think as psychologists, we need to be really focused on, well, what does the research tell us? And the research tells us that that's not true, number one.
Not true.
And number two, a lot of the intervention research, the services research, it looks at these interventions. I talked earlier today in one of my presentations about recovery-oriented cognitive therapy. Very effective strategy for working with people who have very serious mental illnesses, people who we thought would never get out of the hospital, people who would never be doing well, could actually do well. And so on both the outcome, the long-term outcome data, and on the intervention data, we have very strong evidence that it's not a lifetime diagnosis. And we have to make sure that we're trained in a way that can get those positive outcomes.
Yeah. In India, in state hospitals, A psychiatric can look at 200 patients a day, 200
Yeah,
of them
that's
in a
that's not
day.
that's not treatment, right? That's not good
Uh,
clinical care. Yes.
yeah, and there is still a lot of resistance in involving clinical psychologists, counseling psychologists, rehabilitation psychologists, team up to take care of these patients. And we have a long way to go. But besides patients with diagnosis of psychosis, I would also like to bring forth the plight of all those who are addicted to substance, and they are given up on,
Hmm.
as to they are fated to have a no life. They don't have any career. They are not eligible for marriage. They are not eligible for having a family.
Hmm.
And also, a vast majority of diagnosis of ASD, autism spectrum disorder,
Hmm.
or ADHD also gives such hopelessness to
Hmm.
people. What do you have to say about these two things?
Yeah, yeah. Well, I think it's the same story. I think one of the most important things that we can do for people as psychologists is to give them hope.
Hmm.
And that starts with one, us knowing what the research and the literature
Hmm.
says, so that we can speak with confidence that
Right.
people can do it. Secondly, giving hope, I think, involves engaging the people that we're working with so that we're not the quote experts, but we are bringing expertise and understanding that the person has that we're working with has expertise because they can articulate in ways that are very powerful what their recovery journey is
Yeah.
like. And one of the things I would really strongly suggest, as you know, your country is thinking about this, is how do you empower people with lived experience, people who have had serious
Yeah.
psychiatric illnesses who have gotten better,
Hmm.
to put a face on that
Hmm.
and to talk about their experience and talk about what helped them to recover. That was a big turning point, I think, in the United States because there's so much stigma around mental health. No
Yeah.
one wants to be associated with having a
Yeah.
mental health issue. No one wants to be associated with having an addiction.
Yeah.
But when those people can stand up and say, "Yes, I had that problem.
Hmm.
Now I don't," it gives hope to other people
Yeah.
that they can also
Yeah.
so
I think
do
this is
well.
this is what Alcoholic Anonymous did very
Yeah,
beautifully.
yeah,
You know.
they did. But the one thing that they didn't do is they made it anonymous. And
Yeah.
so people recovered, people
Hmm.
got better, but because they were anonymous, no one ever knew that. So you
New.
were
Yeah.
working with a person
Hmm.
who recovered from alcoholism,
But you
but
don't
but
know.
but you don't know
Hmm.
it. What is happening now in the new recovery movement in the United States, people talk about putting a face on recovery. I often say the I think it's seven most powerful words that
Hmm.
I
Hmm.
hear is when people introduce themselves this way. They will say, "I'm Arthur. I'm a person in long-term recovery, and that means," and then they say, "I haven't had a drink or a drug in 5 years, 10 years, 20 years." And they say that publicly. And that
Wow.
makes a huge difference
Wow.
because you have these well-known people, prominent people, people in business, people in education. They're
Hmm.
saying, "I'm in recovery."
Hmm.
And that makes a huge difference in terms of
Yes.
people seeing the possibility and the hope for recovery.
Yeah. And when you're talking about stigma, it is so much ingrained in the society
Hmm.
that we can see that people suffering from mental health issues are not even seeking help.
Hmm.
And
Yes.
there's a lot of coercion or persuasion required. In my office, I feel 3 out of 4 people need coercion to take medication, even if temporarily.
Hmm. Hmm.
And the thing that they would come up with is that once I start psychiatric treatment,
Hmm.
I will be, doomed for life.
Yes.
They will
Yes. Yep.
never allow
Hmm.
me to come out of it.
Hmm.
And,
Hmm.
there'll be so many side effects. I'll
Hmm.
not be able to function in my normal
Hmm.
life.
Hmm.
And this is the current situation in
Yeah,
India.
yeah, yeah. Well, and people have those thoughts for good reason because for many people that has been their
Hmm.
experience. One of the things that I don't think we pay enough attention to in our field is the iatrogenic effects of our treatments. And
Yeah.
iatrogenic, obviously, for your viewers,
Yeah.
simply means that the treatment itself causes other problems, right?
Yes.
So side effects and
Mm.
those kinds of things.
Mm.
Well, one of the side effects of our approach to treatment has been hopelessness and helplessness,
Yes.
because
Yes.
we make people patients
Yeah.
and dependent on us to tell them how they can
Yeah.
recover.
They feel
And
that
yeah,
they're losing control
they're losing
on.
control, and
Yeah.
no one wants to do that. And I
Mm.
think, one of the things that we did when I was mental health commissioner is we radically changed many of the programs. So when traditionally, if you would go to, say, a residential program or an inpatient program, you come in and you would be oriented. So here's the schedule of the day. Here's what time you get up. Here's what time you go to bed. Here's what time you'll eat. Here's when you will go to the group. And so it was
Yeah.
all professionally driven.
Regimentation.
That's regimen. So we radically changed these programs to have more of this recovery orientation. So what did that mean? You come into the program, and rather than being told what you're going to do, they would be asked, how can I help you with your recovery?
Yeah.
Think about that, right?
Yeah.
You go to a program and they ask you, what do you, oh, you mean I get to decide,
Yeah.
or I
Yeah.
get to have a role or voice? And so what happened was, and this was so powerful, there was one of the residential programs, this is for people with addictions, really serious addictions. Usually people would go in those programs and they would leave after about a month or so. They wouldn't finish.
Yeah.
But when you come into the program and they ask you what you want to do and what you want to work on, and the people in the program are saying, we're here to help you achieve your goals.
The motivational interviewing by Rolnick
That's
and
right.
Miller.
That's right. That's right. That's exactly it. That's exactly.
They changed the entire thing
That's
with
right. That's right.
people with addictions, and
That's right.
they started treating them with respect and with dignity, and that
That's right.
they are humans, they are people,
That's
and
right.
they have their opinions and their choices,
That's
and
right.
we can sit with them and talk to them about themselves.
That's right. That's right.
Giving them
and to ask them questions about what their strengths are, not just what are all of the things that are wrong. Because the typical assessment is, tell me, it's 30 minutes or an hour of telling everything that's wrong with you.
Yeah.
Who wants to do that?
Yeah.
No one wants to do that.
Yeah.
But the programs that I was telling you about, we had people stay in those programs for up to a year.
Yeah.
Because they felt like they were in control, that they had a say, that people were working on something that was relevant to them. And the one thing that I would encourage, the people that might be listening to this is, because the world is a certain way now, doesn't mean you have to walk into that world and just can maintain the status quo.
Yeah.
That's why I talked about 3 phases of my career. I came into the field thinking the way many people do, but I'm ending my career thinking very differently about people and the role that they play and the role that I play in that. And it takes all of us working together to
You're
make those
definitely
kind of
not
changes.
ending your career.
Well, not now. Yeah, I should say I'm at the end of my career. Not ending my career. No, I still do some work. Yeah.
And Arthur, when we're talking about the medical model, in India currently, the government is thinking of psychology and psychologists as if they exist only within the medical model. Wherein the other specialties, the experts in other branches of psychology, like you were talking about change management in organizations. So we have the industrial and organizational psychology is not getting its due, and people are feeling left out. They're feeling hopeless about their careers, especially early career psychologists who are now about to enter into the world of practice and the world of their jobs, are really in need of some sort of direction, a ray of hope, a light as to how to progress in this career, and whether does the world need psychologists? Are we there in the right profession? Should we continue to be here, or should we move out of psychology?
Yeah, no. Well, I hope you continue to stay in psychology. I think it points to something that's very important, and that's the importance of organized psychology. If we're trying to deal with these issues as individuals or even a small group within a facility, we're not going to have the same kind of impact. This is really argues for a national or a regional psychological association that can pull together people that can do advocacy. And what I would say is that advocacy should not only be psychologists, but the people with lived experience. That's when you really have the power, when you partner with and you have people who are advocating for you, saying, I'm a person who has a psychiatric illness and we need more psychologists who can talk to me, because when I was in treatment, I didn't, someone came to me once every 3 weeks and gave me medication, but they never talked to me, and I didn't get better. So hearing that from someone with lived experience is going to be even more powerful than hearing it from us. So,
but there's a great problem over there, because the people getting treatment would not like to come out.
Yeah. And that's probably true, but I think it takes one person or a few people, and to make it safe to do that, I think it's going to be very hard to help people if there is continued stigma, because people just aren't going to reach out for help. People won't want to be associated with it. And it's going to be hard for people to address stigma if no one is willing to say, this
that
affects me.
I got better.
I got better. Yeah. So someone has to be able to say, I got better. So I think, and then again, so I think if psychology can partner with those people, organizations that are speaking on behalf of people who have lived experience, that can be a very powerful thing.
Yeah. So now coming to the wellness part of psychology, because I feel that illness is just the tip of the iceberg. There's a lot that people are, suffering. They're in distress. They're upset about so many things. I mean, there are people who are upset because they are not being able to choose a right career for themselves, for instance, or their relationships are not going right, or maybe they are having challenges in parenting, or maybe in school they are not having friends, or isolation, or loneliness, all these things which have not come to the clinical threshold but is there. So how far do you think that psychology should start intervening in the community at the education level?
Yeah. Well, this goes back to the whole population health approach, because what population health says is we're interested in everyone, whether you have a diagnosis, whether you don't have a diagnosis, whether you're somewhere in the middle where you're at risk or having subclinical issues like you're describing. And across that whole continuum, there are things that psychologists can do. At the end of the continuum where people are having a diagnosis, that's where we bring our skills as clinicians to help people to address that. But we shouldn't stop there. The issues that you're talking about, people who have subclinical issues, they don't have a diagnosis. There are things that we know as psychologists who can help them. We can help people reduce their stress levels. We can help people manage symptoms of anxiety. They may not have a diagnosis, but they clearly could benefit from our expertise. And then at the end of the continuum where people are don't have a diagnosis, they don't really have problems, what we can do is two things. One is to help prevent people from moving up that continuum by giving people strategies and coping mechanisms to prevent or lessen the likelihood of developing an issue. And we can help people promote psychological wellness. So moving away from this idea that the only thing that we should be concerned about, as you say in the medical model, is to treat illness. But what we're really concerned about is psychological health. And we're interested in the psychological health of everyone being thriving and so forth. So I just say one other point about this. I think one of the real significant things that gets in our way is this whole diagnostic approach that we have to health. And in our country and in most countries, you cannot get help if you don't have a diagnosis. But we know, as you just mentioned, sometimes we need help even if we don't have a diagnosis. And so our orientation around having a diagnosis before we can help people is it's problematic all over the world. And one other point I would say about this, one of the reasons that I feel so strongly about population health, looking at the whole continuum of the population, is because I have worked very hard with helping people at the deep end, what we call the deep end of the pool, or the people who have the most serious problems. And one of the big problems is that we have, you're on the camera, right?
we're on the camera. We're recording. It's okay. It's okay. It's okay.
That's okay.
That's okay.
They'll edit it.
This is yeah. Yeah.
No problem. So what? So one of the reasons I feel so strongly about population health is because I spent most of my career helping people who have very serious addiction and mental health problems. And the thing that I learned, a couple of things I learned. One is that we intervene way too late. We're waiting until people are in crisis before we help them, or people are in crisis before they will reach out to help. So if we work with people much earlier, we could prevent a lot of people from getting to that point. And it would actually reduce the demand. But the other thing is we act as if we are the only ones who can help people. And when you think about population health, one of the real, I think, interesting strategies is helping to empower people. There's a term called behavioral activation. So behavioral activation simply means rather than me waiting for to go to a professional, there are things that I can do myself to keep myself healthy. I mean, we do that for physical health. Most of us know that.
Self-care initiatives,
Absolutely.
So like you do yoga, you can do mindfulness.
You can do mindfulness. We know, like, if you're, for our physical health, we exercise, we diet, we do a lot of things that keep us physically healthy. What we haven't done is the same kinds of things for our mental health. There are things that we could do that can help protect our mental health, that can help promote positive mental health. And we ought to be teaching people about those things.
Yes.
And helping people.
And I have a couple of more questions when you were talking about all these things. I have felt that, when we learned developmental psychology and we read about Erik Erikson's theories and all these things, that helped us in our lives as well.
Absolutely. Absolutely.
And I always feel, why are our researches, our thesis, our dissertations kept in the psychology fraternity? Why aren't they going to the public who need it?
Absolutely.
I mean, why aren't we teaching developmental psychology to all the parents?
That's right.
They could use it.
That's right. Yeah. As a great example of what you're saying, when I was commissioner, many kids in the city that I was mental health commissioner in were being kicked out of summer camp. And they were being kicked out of, so can you imagine, you're a kid, you go through all the school, you get to summer camp, and then they kick you out, and they were kicking out like 100 kids every year. And so they came to us and said, can you help us with this? And we said, okay, so what we're going to do is we're going to teach you about normal childhood development, which, and basically that's what we do. We say, here are behaviors that are normal and typical for children at this age. And what it did is it gave the people who are not clinicians, these were camp counselors, a different way of understanding that. And, the next year it went from like 100 to 3, right? That's a huge difference. This is a huge intervention, right? And it was simply by what you're saying, which is teaching people the things that we know intuitively from our training.
Why can't we teach attachment theories to people who are going to get married?
Absolutely.
They can navigate their relationships as well.
Absolutely.
And so I have always believed, this is the tagline of my company, psychology is for everyone.
I love it.
It's not just for, psychologists to keep it to themselves. Why can't we teach it to anyone who is interested in it?
And we should. And that's what a population health approach is. It's saying, let's not wait for people to come to us so that we can treat illness. It's us saying, as a field, not everyone is going to work across that whole continuum, but we should have a cadre of psychologists who are really focused on teaching people attachment theory and developmental theory and strategies that people can use to reduce stress. We should have a group of people that are working with people that are doing those subclinical issues. They're struggling maybe with stress, or they're struggling with anxiety. They don't have a diagnosis yet. And we should have people at the other end of the continuum where we're doing what we typically have done, which is treating illness. We need to have psychologists across that whole continuum.
The continuum.
Yes.
And instead of having a hierarchy, we should have a collaborative
That's right.
circle where,
That's right.
the medical professional are also a part of the
That's right.
team,
That's right.
where, there is a, and so a linear approach rather than a vertical approach could
Yeah.
be ideal and could be what we
Yeah.
should be aiming at.
Yeah. That is such a good point, and I think that's important in two ways. One is, especially if you're thinking about this population health approach, one of the things that it does is it moves mental health from being about them to mental health being about us.
Us.
Because
Yeah.
I have mental health, you have
Yeah.
mental
Yeah.
health. It can be good or bad. We
Yeah.
all move up and down that continuum over the course of our
Correct.
life. And just saying that we all have mental health helps to reduce the stigma. Some of us, unfortunately, get to the point where we need professional help. Some of us don't, but all of us are somewhere on that continuum. And I think the other thing that perspective does is, as you're saying, when we start to think about ourselves as a team, what we know is that no one discipline or no one thing is everything that people need in order to recover. Sometimes people
Nothing
need
is panacea.
no,
Yeah.
that's right. That's right.
Yeah.
Sometimes people need rehabilitation. Sometimes
Mm.
people need recreation. Sometimes people need medication. Sometimes people need housing. So when we form that kind of team that you're
Yeah.
talking about, what we can do is put together what each person needs, which is going to be unique. We don't all need the same thing, but we need a range of things to help us recover.
Yeah. Yeah. Yes. And I don't want to end this conversation.
Yeah.
But I know that both of us are hungry and it's lunchtime. So I'll just ask one last question, Arthur. What is it that we can do to inform the policymakers? What should be the steps that we should be taking as psychologists so that they become more open and more encouraging to towards mental health like they are for physical health?
Yeah. A couple of things. One is I think it's important for us to have build consensus around a framework. So we've talked a lot about population health. I think that is the way that we have to go if we're going to really reach the numbers of people that we need to reach as a field. And so, number one, I would really want to build consensus around that and get buy-in from across the field around that.
Yeah.
Secondly, I think organized psychology has to partner with other entities to make the case for using these approaches. And thirdly, I think we have to show the utility and the value of what we do. And surprisingly, one of the ways we do that is by helping individual members of your parliament or your government, because I can guarantee you there are people in the executive branch of your government, there are people in your legislative branch or parliament who have these issues themselves, or they have family members.
Yeah.
And so when you can reach out to them and help them, they become an ally. They become an ally, right?
Yes.
So it's just finding those people, helping them. Those are the strongest proponents of changing the laws and funding in Congress, in our Congress in the United States, are people who themselves have been helped personally by people from our field. So it's another thing for us to really hone in on.
Thank you so much, Arthur, for that. And I'm so looking forward to having you in India.
Yeah, I'm looking forward to being there. Yes.
Thank you so much.
Yeah, thank
Great
you.
talking
Thank
to
you.
you.
Thank you.